Um, we have a reflection from a dear friend, Travis, today. But before we transition to Travis, I'd love for anyone who has a case to please volunteer to do it for Reza and I to discuss it. We cannot do it without you. So if you have a case, please jump on in to present it. In the meantime, we'll pass the mic to Travis to share a reflection on yesterday's fantastic virtual morning VMR case from Tarek. All right, Travis, take it away.
Thank you. I think yesterday was an awesome case. I think, we waited kind of to the very end, and lo and behold, we had, I think it was a gem. One of the reasons why I felt like the case was a gem, one, it was an awesome learning opportunity that Tarek presented about his mentor, reflecting on, what he didn't do. But I feel like that's something we all do. And, when there's common complaints that we get, like chest pain and shortness of breath, when we consider the base rate of a disease like heart failure, ischemic heart disease, especially with the patient yesterday was 92 and just had an LAD stent within the last year. It looked like a duck. It smelled like a duck. It quacked like a duck. It had to have been a duck. It had to have been heart failure. And it turns out it wasn't. But one of the things I feel like, back to the basics, right? So when someone presents to the emergency department with chest pain or shortness of breath, I think we're quick to draw, let's get an EKG, a chest x-ray, a CBC to look for anemia, a chemistry panel, maybe some LFTs, a troponin, a BNP, to look for the common things. Pleural effusions, the patient had it. I don't know if there was a BNP on that as well. But, if that's high, it kind of, adds to our maybe our bias on what we think is the cause. One of the things that was missing, I feel like initially, and I don't commonly order urinalysis on patients presenting with chest pain or shortness of breath, but turned out to be the key and the pivot point to this was the urine. You see all of the protein in the urine. And then it became, voila, a heart failure case to a nephrotic syndrome. And I feel like the discussion yesterday, going over nephrotic syndromes and how it's a histological based, diagnosis, needing tissue versus nephritic syndrome. I think it was a wonderful way that how the day turned out. We got a common case that turned out being nephrotic syndrome and the diagnosis of primary membranous glomerulonephritis, diagnosing it with a PLA2R. So it was a great case, a lot to reflect on. And, one of the things that I definitely won't bias myself into, the urinalysis, even though it's the test that takes the longest to get back because it requires, the patient to provide it and, maybe it to be collected. But sometimes it is important. So those are my reflections.
I love that, Travis. I absolutely love that. I'm right there with you. I think it's humbling to go on that journey. I saw what you said in the chat yesterday. If it looks like a duck and quacks like a duck, it might be a zebra. And I think that that is what keeps us on our toes all the time, And, I think at the end of the day, I think it's okay to think it's a duck. And only when things are not improving do you really have to think, oh, wait, no, it actually might be a zebra this time. Thank you for sharing that reflection and for being ever present on VMR. Another ever-present individual is here today too. Anne-Marie, it seems like has a case. I will transition to you, Anne-Marie, to reintroduce yourself, although I think that it's kind of silly and more tradition than anything else. And Kiara, I can hear the puppy squealing. Yes, that's right. He's running around here down. So Anne-Marie, if you, Reza's on his way. Reza's on service right now and actually had an acute event that is making him a few minutes late, but he'll be here. In the meantime, do you want to unmute yourself, introduce yourself to the VMR crew, and then we can actually get going right after you do that. I apologize, folks. I'll have to have my video off for most of this because the service down here is a little bit spotty, but I can't wait to tackle this case. All right, Anne-Marie, take it away, please.
Okay, well, I'm happy to present this case, although it's not fully prepared, so I'm probably going to be scrambling.
I love less prepared cases. I think they're way more fun, quite honestly.
So I might be scrambling for some lab values, but I'm
okay. Scramble away, make them up, do whatever you need.
I'm a hospitalist, and this was an interesting case that I saw on the teaching service that I felt like had a really good differential. So I'm excited to present it and hear everyone's insight on it. And then do you want me to just go ahead and start?
Yeah, why don't you kick it away and I'll try to update Reza. I think Sukriti is doing the scribing. So Sukriti, please take away the screen and we'll jump right in.
Okay. Um, So this is a case of a patient who was transferred from a nearby hospital. He had presented to the hospital a few days prior for left facial droop, right leg weakness, and dizziness. He is a 45-year-old male. With a past medical history of rheumatoid arthritis, a COVID 5 months prior, a renal infarct 4 months prior, and then a positive untreated strongyloides antibody in the past. And then I will leave it up to you whether you want more HPI or just want to reflect here.
Well, I'm happy to reflect here. I think this is a lot of information, and I think you're setting us up with the HPI to reflect on what sounds to be a very scary neurological syndrome. It sounds like we have a patient with sorry for the constant squeakiness in the background. Um, this is a patient who's presenting with facial droop on one. I think it was a right-sided facial droop. Is that right? Like do you mind just reminding me what the sides of the um, yeah, it was right facial droop and left leg weakness. Is that right, Anne-Marie? Hey, Anne-Marie, are you there? I think you're still on mute.
It was left facial droop and right leg weakness.
Okay, so it's left facial droop and right-sided leg weakness. And so, at the get-go, when you're trying to localize this neurological syndrome, you immediately are in a world of cross signs, and cross signs is a reflex to think brainstem. Now, that's not necessarily the conclusion that you'd come to right away. But if you systematically analyze left-sided facial droop, you trying to put my thoughts together. So left facial droop, either upper motor neuron or lower motor neuron. Lower motor neuron facial droop means by definition that you're dealing with in most cases a Bell's palsy. But the craziest thing about Bell's palsy, it is usually an isolated neurological syndrome. So most patients with Bell's palsy will only have facial droop and will not have any concomitant signs. So immediately when you hear the words facial droop and you hear other neurological symptoms, you know you're dealing with a sinister cause of facial droop. Sinister causes don't mean that the lesion is central. There are sinister causes of a peripheral facial neuropathy, but that would mean it's not Bell's. Bell's, by definition, means it's idiopathic and otherwise neurologically silent, and no systemic cause is found. So immediately we hear left facial droop and we're like, it cannot be Bell's, but is it central or peripheral? And the concomitant neurological features here, right leg weakness and dizziness, would probably prioritize a central cause in the brainstem over multiple peripheral nerves involved. So here at the end of the day, you're probably like, I know the lesion is not Bell's. It could be a seventh peripheral nerve as part of a systemic syndrome like sarcoidosis that's affecting the facial nerve and affecting the right side in some way, shape, or form. But the overwhelming odds are the simplest way to localize this lesion is to say that there's something wrong in the brainstem causing facial droop, causing right leg weakness and dizziness. But we haven't ruled out a peripheral cause. So that's the setup that we're in. And how does the background data help us? The background data, some of it is very clear, some of it is unclear. Now, why did this patient have a renal infarct 4 months prior? The timing of which seems to be related to around the time of his COVID diagnosis. So that's a possibility. He could have had the hyperthrombotic phenotype of COVID. But you'd have to retrace the steps and say, like, did this patient have a thrombus related to COVID, or was there some thromboembolic vascular phenotype beginning even at that time? COVID, it's hard to relate COVID to a brainstem syndrome 5 months later, But I think we've all been humbled by what COVID can and cannot do. And so we'll keep that as a question mark in the background. How can RA be related to the symptom complex? The overlap between rheumatoid arthritis and neurological disease is only present really when rheumatoid arthritis is uncontrolled. The most common complication of RA and neurological disease is what's called atlantoaxial instability, or the C1, C2 vertebra is unstable, and that can cause a compressive neurological syndrome, but that usually is in patients with advanced untreated rheumatoid arthritis. But if you're, the other overlap is when you can have rheumatoid vasculitis, and rheumatoid vasculitis in untreated patients can cause the renal infarct, no doubt, and cause a brainstem syndrome. So to summarize, where are we at? I mean, we're in esoteria here. We're in esoteria because the most common reason why somebody comes in with a left-sided facial droop is they have Bell's palsy, and in those patients they have no systemic symptoms, no other neurological diseases, and immediately this case takes a sharp turn away from that very common and usually benign possibility. And then the question is, well, where is the problem? It could be peripheral facial nerve and then peripheral explanations for everything else. But the most common location is likely the brainstem. And the brainstem diseases come in many, many varieties, and you have to use the background data to help you understand what that could be. And the background data suggest autoimmunity. The background data suggests some sort of vascular phenomenon. And where we land up is probably initially getting clarity on the current syndrome, prioritizing, of course, a vascular phenomenon since it's very treatable, but here recognizing that the tempo is less consistent with a sudden vascular event. So I'll pass the mic back to you, Anne-Marie.
Awesome. So in further regards to the HPI, the patient reported 2 weeks of some difficulty speaking and swallowing, as well as a feeling of sore throat. Also reported in this time frame blurry vision, but that had been ongoing for a few months. And then headaches over the past 2 weeks that involved the whole head and were sharp in nature, and then several weeks of generalized weakness, and then also kind of pain in the elbows, knees, wrists, and shoulders, which was consistent with prior pain from rheumatoid arthritis as well. There were no fevers present, no night sweats present. The other hospital presented with an elevated white count, was very tachycardic in the 130s on admission, received a CT head that did not show acute abnormalities, and then a CT of the abdomen and pelvis that only showed chronic renal scarring from the past infarct. Also had a chest x-ray and a urinalysis that did not show signs of infection, was started on broad spectrum antibiotics, and blood cultures were drawn. The MRI of the brain showed multiple acute to subacute infarcts involving the right corona radiata, left corona radiata, and right periatrial white matter. In regards to further on past medical history, the rheumatoid arthritis was characterized by both RF and CCP antibody positivity. Care had been very intermittent due to multiple barriers in care and was not currently on any treatment for that, but in the past had been on steroids as well as a TNF alpha inhibitor, but none in the past 6 months. And then the renal infarct was diagnosed at another hospital. Notably, there was positivity in the antiphospholipid panel at that time. Was started on apixaban, but could not actually afford to get the medication, and so the patient had not been able to take that medication, unfortunately. And then also after discharge, an ANCA antibody came back positive as well for that, but that had never been worked up at that time. Did not come in taking any medications aside from just over-the-counter Tylenol and NSAIDs for the pain. No current past tobacco use, but no current tobacco use, no current alcohol or other drug or substance use. And then family history was just positive for a mother with rheumatoid arthritis as well.
Holy smokes. I feel so badly for the person who had to jump in, and presumably you, Anne Marie, digest this data and begin to make progress with it. There's just so much going on. And in this complexity, I want to thank you for being able to present it so clearly, because I think I would be so lost in the heat of battle in the moment taking care of this patient. But there is one, I think, deeper truth. And that deeper truth is whenever you're faced with a systemic syndrome, and the case for systemic syndrome here is robust, there's a tachycardia, which is presumably sinus, which is your first clue to a systemic syndrome. And then you're dealing with leukocytosis, meaning inflammation. You have renal involvement, and then you have brain involvement, and the joints are involved, the soft tissue is involved. So you have a systemic syndrome. And the easiest way to make progress on a systemic syndrome is to ask, is it something that is disseminating everywhere inherently, like a metastatic tumor or an autoimmune disease like sarcoidosis that can go everywhere? Or is there an actual pattern to the way it's disseminating? And that pattern here is apparent. Here, that pattern is there's dissemination through the vascular system. Now, how do we know that? We know that based on the MRI findings of multiple brain infarcts and the knowledge that there was an renal infarct before. So this disease is not metastatic disease. It's actually local disease within the vascular system. And it happens to be that the vascular system is present everywhere. So I'm taking a leap here. I'm taking a leap and saying I'm not dealing with a multi-system disease. I'm dealing with a vascular disease. And whenever you're dealing with a vascular disease, there's a key question. Is it inflammatory or non-inflammatory? And I think that in the presence of untreated rheumatoid arthritis and elevated white count and sinus tachycardia, there's enough data to say I'm dealing with an inflammatory vascular disease. That explains the neurological findings, and that explains the renal findings, and is a great anchoring schema to begin to digest this case. Though you wouldn't commit to that because there might be an extravascular focus of disease like a cancer that results in a paraneoplastic vascular fingerprint. So you might have an undetected carcinoma, for example, that's causing hypercoagulability, and you still have to find the vascular disease, but are on the hook to find the trigger for it. But I think it's a good place to start, to be like, can I solve this vascular representation, recognizing that might not be the entirety of the problem at hand. So how do we begin to do that? Whenever you see an occlusion, you have to ask two key questions. What and where? The what is the humble recognition that bland thrombus is not the only cause for occlusion. You may have occlusion because you have pus, endocarditis. You may have occlusion because you have metastatic tumor everywhere, clogging up cells. You may have, like a myxoma, for example. You may have occlusion because you have calcium from a stenotic aortic valve that's flicking off everywhere. So the key question here, I think in this case is it tumor clogging up vessels? Is it pus or is it bland? And we can't make tremendous progress on that hypothesis yet, but have to increase the probability of endocarditis solely based on the presence of inflammation here. So that's the what. It's probably bland because that's what the base rate would prioritize. And it's it could be endocarditis because of the inflammation. Now, where is the key question? Where is the occlusion? Is it an in situ thrombus right then and there, or is it coming from a common origin? The where is a much easier question to answer whenever you have multiple foci of clots. You can be like, well, the odds are that they're originating in the common path. No different than when we say that a patient with pancytopenia, multiple cell lines down, likely has a bone marrow problem. Whenever somebody has multiple areas of occlusion, they're likely having an embolic source, a source from the heart or from the proximal vessels. So here, the where is there something wrong in the cardiac chambers or the aorta before the brain and before the renal artery? But a hyperthrombotic state can cause clots everywhere, no different than lupus can cause cytopenias peripherally of every single cell line. Lupus can destroy white counts, hemoglobin, and platelets independently and not do anything to the bone marrow. And no different here, can we have a hyperthrombotic thing like APLS that can cause clots everywhere. So let me summarize before we reflect some more. One, the biggest possible shout out to the human being who had to digest this data and make progress on it. And kudos to you, Anne-Marie, for likely being that person, but also more importantly, being able to summarize it so cohesively for us here. This is a multi-system syndrome, which is either something disseminating everywhere or actually that the problem is in a system that involves every organ, the vascular system. The radiographic signature of a renal infarct and MRI with multiple thrombi prioritizes a problem in the vascular system. And when that problem when we're trying to solve that problem, we ask two key questions. What? Is it bland thrombus or pus? And where? Is it originating in the heart or the aorta, or is there such a hypercoagulable condition that you're having clots everywhere? Now that's the 10,000-foot view. Let's talk about the specifics. A bland thrombus has many, many, many different causes to it. Getting a clot as an older adult may happen for many reasons, but the priority should be thinking about cancer, thinking about APLS, and thinking about vasculitis as the three common causes of an ultra hypercoagulable condition. So for me, when I see somebody throwing clots everywhere, I think, okay, could this be a proximal source, like something in the heart, or is this patient having ultra hypercoagulability? And ultra hypercoagulability usually lands on cancer, vasculitis, and APLS. And unfortunately, rheumatoid arthritis untreated is associated with cancers, specifically lymphoma, so that has to be on our list. Untreated rheumatoid arthritis is associated independently with what's called rheumatoid vasculitis, which this syndrome is very compatible with. And rheumatoid arthritis is less commonly than lupus, but certainly associated with APLS. So there's a lot of work to be done here, but the focus is on making sure you understand where this is coming from, look at the heart and the aorta, and understand the what. Is this endocarditis or not as the next key steps. I'll pass the mic back to you, Anne-Marie.
Awesome. So sorry, let me pull up my sheet. So as far as vitals upon admission to this hospital, the temperature was 35.8 degrees Celsius. The heart rate was 97. The respiratory rate was 16. And the blood pressure was in the systoles of 130s to 150s over 80s. The oxygen saturation was 97% on room air. On examination, he appeared uncomfortable due to pain, but was able to answer questions. On HEENT exam, had a white coating on his mouth, which did scrape off upon examination, and also had some decreased range of motion in the jaw, as well as some dental caries, but no obvious abscess was seen, no significant cervical lymphadenopathy. As far as the heart exam, it was slightly tachycardic, but without murmurs, no chest wall tenderness. The lungs were clear to auscultation without accessory muscle use and good air movement. The abdominal exam was not remarkable. As far as his neuro exam, he was alert and oriented. The cranial nerves 3 through 12 were intact. The left facial droop had resolved at that point. As far as his strength exam, his strength was 5 out of 5 in the left upper and lower extremities, but 4 out of 5 in the right lower extremity diffusely, as well as having decreased sensation. He also had some right-sided dysmetria. And then he did have some dysdiadokinesia as well in his hands. As far as the skin exam, there were some hypopigmented lesions throughout the skin. And then there were a few like kind of scattered nodules, which were palpable on his bilateral hands and forearms. And then just like some bilateral upper extremity kind of reticular erythema that was a little bit non-specific. His extremities pulses were intact to palpation, and he was warm and well perfused.
Boy, this is.
Do you want me to give initial labs here as well?
Maybe.
Hey, Robbie, I'm here as well, so I'm ready to take the mic and give a little bit of a response once Anne-Marie shares the laboratory data.
Here, why don't I do this, Reza? Why don't I summarize what's going on, reflect on the exam, and then have you take the data?
I heard all of your explanation in the first two
or
the second aliquot, so I'm up to date. But feel free to summarize if you want to.
Oh no, if you're good, let's get the lab data and then hand you the mic.
Thank you.
So the initial laboratory data showed a WBC of 10.9, and that was neutrophil predominant at 8.3 with a lymphocyte count of 1.3. The hemoglobin was 10.9 with an MCV of 96, and the platelets were 571. And then as far as the CMP, the sodium was 133. The potassium was 4.7. The chloride was 106. The bicarbonate was 19. The BUN was 11. And the creatinine was 1.31 from a baseline around 0.9. The glucose was 66. The calcium was 9.1. The magnesium and phosphorus levels were normal. The albumin was 2.6. The total protein was 5.9. The bilirubin was 1.2. And then the AST, ALT, and ALK phos were completely normal.
Anne-Marie, is this a good place to start commenting?
Yeah, go for it.
First of all, I want to apologize to everyone for showing up a bit late. I'm on service right now. We had a sick patient, and looking at this whiteboard, I started getting a little bit of palpitations. This is a striking presentation of a young person. So I totally agree with the mathematician, and I thought the number one concern is some form of endovascular infection. Now let's look at this physical exam. We're looking for signs of inflammation. The temperature is normal, but that does not rule out, although it's specific for fever and inflammation, it does not rule out the possibility of inflammation. The patient's a bit tachycardic, which may be consistent with an underlying inflammatory process, because that's going to be key in trying to identify what's going on here, is to either frame this as inflammatory or non-inflammatory. So I'm going to quickly go to the labs, because since we're asking that specific question, for inflammation, typically we might see a leukocytosis where you have neutrophil demargination due to the stress of inflammation. We don't see that here. Maybe a slight leukocytosis based on what the upper limit of the lab test is. But then you shift your focus to the platelet count. And we see that the platelet count is 571,000. That can be a marker of inflammation. And not any kind of inflammation. For autoimmune diseases, usually seronegative. For cancers, usually solid cancers. For infections, usually atypical infections. We have to be a bit cautious with interpreting that platelet count because this patient does have rheumatoid arthritis, has been off of immunosuppression, so has a reason for chronic inflammation. What we're trying to determine is if there an acute component to this patient's presentation, an acute inflammatory component. You look at the chemistry panel and the liver chemistry test to try to determine, is this disease leaving a signature anywhere else? We see that the liver chemistry tests are not inflamed, so unlikely to involve the liver. The creatinine being 1.3, it has grabbed our attention, and we know that this patient has a history of renal infarct, but oftentimes renal insufficiency is due to some kind of pre-renal azotemia or hypoperfusion. So it often is a bystander as opposed to a robust signal to incorporate into your clinical reasoning. Nevertheless, we have to entertain the idea of an intrarenal cause of acute kidney injury. So we'll follow what this patient's creatinine does, and we'll look at a urinalysis. In general, I don't associate rheumatoid arthritis vasculitis involving the kidney. As Robbie said, the skin, the brain, the eyes are our thoughts with RA. Now let's get back to this physical exam. The white coating on the mouth is concerning. It suggests thrush. Now, patients can have thrush because they're immunocompromised or have impaired cell-mediated immunity, or they can have thrush because they've taken antibiotics. You can also be fooled when someone is extremely dry, has dry mucosa, they can develop whitish residue that easily scrapes off. But if we incorporate this, and we should consider the more morbid possibility, we can now frame this person as more immunocompromised. But this will prompt an HIV testing for sure, independent of that absolute lymphocyte count. The neuro exam is fascinating because when you're talking about right lower extremity weakness, you can put the lesion in the contralateral hemisphere, and you can also come down the spinal cord all the way out to the nerve root. But then the dysmetria, the dysdiadochokinesia is not sensory ataxia. This is cerebellar ataxia, and it puts the lesion at the ipsilateral lateral hemispheric area. So the cerebellum, 2 hemispheres, and each cerebellum has a vermis and it has lateral hemispheres. This would be a lesion in the right cerebral hemisphere in the lateral part of the cerebral hemisphere, because if it was the vermis, he would have truncal ataxia. So this person has multiple lesions, and we noticed that on the MRI. I'm not sure when that MRI was done. The question now becomes this: what is the patient's immune status? And an HIV test is in order. Blood cultures are in order. And for sure, an echocardiogram to evaluate for some type of vegetation. You may say, Reza, what about the lack of murmur? The murmur not being there is not exquisitely sensitive, and also depends on the clinician's ability to listen based on, the body habitus. But also, if we're entertaining non-infective endocarditis, which has more of a tendency to embolize, it rarely destructs the valve. So you might still have that type of presentation. I'm actually going to ask Robbie here. I'm not yet ready to say inflammation, but I'm not ready to exclude the possibility of an inflammatory syndrome, whether it's subacute endocarditis with embolic phenomenon, or whether it's vasculitis involving multiple vessels. As Robbie said, with RA, you can involve multiple vessels if you have vasculitis. So I'm not sure, I'm not dismissing inflammation, and I would want to know the immune status. And I think my next step would be evaluating the valve and collecting blood cultures.
Okay, ask and you shall receive. So Blood cultures were obtained upon admission at the other hospital, and we called and verified that they were negative at 48 hours. He was originally started on broad spectrum antibiotics at the other hospital, but those had been stopped and we elected not to continue them on admission. Repeat blood cultures were obtained upon admission and were also negative. A TTE had been done the other hospital and did not show any alveolar lesions and showed a normal. As far as the urinalysis, it showed a specific gravity of 1.018 and then a protein level of 30 and positive ketones. It was otherwise negative. The urine protein creatinine ratio was 1 and the urine albumin protein ratio was 0.23. Microscopy showed some, just a few muddy, like granular cells, but did not show any other abnormalities. As far as serologies, the ANA was negative. The complement levels were normal. The double-stranded DNA was negative. The ENA was negative. Hepatitis C antibodies were negative. Hepatitis B showed that was immune. HIV was negative as well. There was slightly elevated kappa and lambda, but the ratio was normal as well. The RF level was 1,200. The CCP antibodies were elevated around 345. And then as far as the antiphospholipid panel, it had since normalized to slide from just a mildly elevated cardiolipin IgG at 28. The ECG showed sinus tachycardia. And then the renal ultrasound with Doppler showed no renal artery stenosis. The creatinine did improve back to baseline with additional IV fluids.
I've always wanted to say this. Please, somebody call an ophthalmologist. It's very rare that the eye issues become helpful in localizing a syndrome, but I really, really am itching to understand what his blurry vision is. Not to gloss over all the data here. I think all the data here is very, very important. And I will tell you that it's a close analysis is going to be important. But the reason I'm itching for an ophthalmologist is I will never reflect on renal abnormalities when Prof. Rez is here. He is the king, queen, and all things of urinalysis interpretation. So I'll pass the mic on to him to dissect that and try to really understand what is the kidney involvement here? How does that help us? I will say that, as Anne-Marie alluded to when you were teaching us while you were presenting, the elevated kappa to lambda ratio is expected here given the kidney dysfunction. The height of the rheumatoid factor actually does correlate with the likelihood of extra-articular disease. So let me take the screen over for a moment to show you an approach to, well, actually, I won't do that because I don't have the note ready. I'm sorry, Sukriti, you can take it back. It'll take too long, and we only have 17 minutes left. But I'll tell you that the likelihood of extra-articular rheumatoid arthritis is heightened in men more than women, is heightened in patients who smoke, is heightened in patients who have RF through the roof, and is, of course, most importantly, heightened when the patient is untreated. And the extra-articular complications of rheumatoid arthritis are really, really centered on the soft tissue and the lungs. The soft tissue meaning rheumatoid nodules, which I suspect this patient has on his hands and his forearms. And lung disease can affect the airways, the parenchyma, the pleura, and the vascula. So RA and lung disease can cause anything. Less commonly so, but important is to recognize the risk of coronary artery disease from untreated rheumatoid arthritis and secondary Sjogren's syndrome, which may be the explanation for the candida if we don't find an immunocompromising condition. But when you get to the less common and more sinister complications of rheumatoid arthritis, that's when you enter the world of Felty syndrome, which is characterized by splenomegaly, neutropenia, and lower extremity ulcers. When you enter the world of an increased risk of lymphoma, and is important to study this possibility of secondary amyloidosis and its effects on the kidney. But the real no miss diagnosis acutely, all those things are important to diagnose, but you can take your time with them. The real no miss diagnosis is, as we've been reflecting on, a rheumatoid vasculitis. And I won't talk more about that, but to tell you that you can tease it apart from the other causes of vasculitis by its unique ocular manifestations. It is virtually one of the only causes of what's called peripheral ulcerative keratitis. It has a propensity to affect the cornea, which is an unusual place for autoimmune diseases to affect the eye. When you think of autoimmune and eye, you think about the uvea, the sclera, the retina, the optic nerve. The cornea is not commonly affected by autoimmune disease. There are exceptions, of course, but I'm really itching for an ophthalmologist or somebody to be like, what's the deal with the eye stuff? But I think at the same time, we have to understand the kidney, and I'll pass the mic to Reza to reflect on that.
I love that so much, Robbie. Like looking for pathognomonic features of a rare diagnosis, and the way you framed it, saying, look, this is a man, high titer RF, off of treatment with ocular, central nervous system, and cutaneous findings, which would be consistent with extra-articular rheumatoid arthritis vasculitis, which quite frankly, if you're ever saying that term, a rheumatologist should be on the case. You need a rheumatologist, not Robbie and Reza. To get to the kidney stuff, really, I think that what we're looking for is there a possibility of a glomerular nephritis or not? And a helpful clue to a GN would be the presence of dysmorphic reds or red blood cell casts. While they increase the post-test probability for a GN, their absence does not necessarily reduce the post-test probability of a GN. But the first step in identifying whether there's a glomerulopathy is to see if there's evidence of proteinuria, and not any type of proteinuria, but albuminuria, large protein. And the urine dipstick only assesses for albumin, and we know that there's albumin in this urine. So we know the patient has albuminuria. We know the patient has some form of glomerulopathy, but are we ready to make the step and say this is glomerular nephritis? I'm not. Patients, the common causes of non-inflammatory glomerulopathy include hypertension, include diabetes. Nevertheless, I would probably check another UA to make sure that there isn't hematuria. And if there is, then I would assess the sediment. But I'm not yet to say that this urinalysis is consistent with the GN. I do think it's consistent with glomerulopathy. So Robbie, I'm right there where you are. I loved your hypothesis of rheumatoid arthritis vasculitis. I still think we must rule out infection, and I still think that we have to assess this patient's immune status because I feel like to end up on that diagnosis, which is going to require probably aggressive immunosuppression, we have to do our diligence in ruling out every other possibility. So what I just learned from you was this sort of unique ocular manifestation. So I'd love that ophthalmologist to tell us what they're seeing and whether that's enough to anchor us in RA vasculitis, or whether we have to go and pursue a TEE and further infectious workup for an endovascular source.
Awesome. So a few things, sorry, it's not very organized, that I forgot to mention earlier. Cryoglobulins were checked and negative. The CRP was elevated around 200. So sorry, just to answer some things I forgot to answer earlier. I do not have an ophtho consult for you, partially because when we checked vision upon admission, it was normal. It had since normalized. As far as further workup, a TEE was obtained and did not show any abnormal valvular lesions. And then an MRA of the brain was also obtained. And it showed decreased caliber of the cortical segments of the middle cerebral artery, greater on the right. And then kind of the read was maybe considered for evaluation of CNS vasculitis. A whole body PET scan was also obtained that did not show any systemic large or medium vessel wall uptake in the body as well. Decided to empirically treat for that strongyloides antibody just in case systemic steroids were needed, and so received ivermectin for that. And then a bunch of different teams were obviously consulting as well. And so I guess I'll let y'all reflect on this, and then in the next aliquot I'll reveal kind of the diagnostic test and what the final diagnosis was presumed to be.
All right, Robbie, let's tackle this one together, my friend. You ready? By the way, I have a paper cut on my pinky because as I was explaining myself to my team today, one of the learners was standing too close to me and I talk with my hands and I moved my arm out and he cut me and it hurts. I should report the learner, but anyways. This is extremely helpful data because one of our primary concerns was endocarditis, non-infective endocarditis. I think with the TEE, and I'm so glad that Anne-Marie and the team obtained that and advocated for it, you've essentially ruled out endocarditis. So now we have to step back. Are we dealing with catastrophic APLS, given the history of APLS, or are we dealing with a primary vasculitis? The MRA, which doesn't require contrast, by the way, the MRA is really pointing us towards a CNS vasculitis. Remember, it's easy to diagnose vasculopathy, but it's difficult to diagnose vasculitis. But this presentation is yelling CNS vasculitis. Now, CNS vasculitis can come in different flavors. There's an infections from fungal to tuberculosis to syphilis can cause CNS vasculitis, but autoimmune diseases can too. And this is where I want to bring in the kidney findings too, because you have to categorize an autoimmune associated vasculitis as large vessel, medium vessel, or small vessel. And here we're getting hits in multiple vessels, so we can frame it as a variable vessel vasculitis. And when you're in that category of variable vessel vasculitis, you can think about rheumatoid arthritis vasculitis, relapsing polychondritis. Cogan's is another cause of variable vessel vasculitis. Now, other causes of CNS vasculitis include lupus, and Behçet's is another variable vasculitis. There's no reason to suspect lupus. There's no reason to suspect Behçet's. Cogan's is usually eye and ear. No reason to suspect that. We do have every reason to suspect a rheumatoid arthritis vasculitis. And Robbie so eloquently in his illness script said, look, man, high titer RF, history of smoking, this patient doesn't have, increases the risk for extra-articular. I'm anchored on these eyes, extra-articular vasculitis. So with this data, I think everything is yelling RA vasculitis. But before I give this patient high-dose immunosuppression, I would want to make sure that we're not missing an atypical infection. So I would send syphilis. I'll do a treponema test and a non-specific RPR and a FTT ABS test. I'm less concerned for fungal infection based on the lack of any like pulmonary or any other. It would be odd to just have vasculitis from a fungus. TB is something to always consider. But again, it would be odd for just extrapulmonary TB to manifest as that. So if we get this RPR back and it's negative, or the syphilis screen is negative, then I think I would ask the rheumatologist, should we start high dose immunosuppression? Thinking like 1 gram of methylprednisolone, and then maybe also initiating some longer term immunosuppression like the cytoxins and stuff like that. Robbie?
Y'all, did you listen to that? That was absolutely brilliant. I have nothing to add. I'm right there with you. And because we've been on a stretch of getting close but not quite right on the answer, I've started to play this game. And the game that I play in my head is there a data point that I am using a lot to hedge on our working diagnosis of RA vasculitis, which I'm right there with you. And I think I'm asking myself, what would I think in this case if the patient didn't have RA? And if the patient didn't have RA, we have a case of a vasculitis that affects the brain and the kidney and has prominent sinus tachycardia and nodules. And that's when I was like, wow, this is a classic presentation of polyarteritis nodosa with renal involvement, brain involvement, and skin involvement. But I don't know the answer to this. I'm now like, how do you diagnose PAN in someone who has RA? I think it's literally impossible to make diagnosis of PAN unless you have histology in a patient who has RA. So I think this patient, here's what I can say for sure.
Robbie, I accidentally muted you. Please unmute yourself. You're about to say this is what I said for sure. I didn't purposely mute you. I was trying to unmute myself.
He was like, shut the hell up and just say you think RA vasculitis too, which is true. But I'm gonna pose a question to the chat. How do you diagnose another vasculitis in somebody who has rheumatoid arthritis? Like, how do you diagnose ANCA? We have a positive ANCA here, and I don't know the answer to that. It's so interesting how the history of rheumatoid arthritis, if you marry vasculitis with a history of RA, without getting up tissue, how do you make progress on another vasculitis? And it's amazing how much we're using the history of RA to say RA vasculitis, but it really could be any vasculitis after you exclude RESA's important infectious considerations. And as Kujal just said, don't anchor too much on the ANCA, and maybe don't anchor too much on the RA. But it really seems to be screaming RA vasculitis to me too. But I have to think a lot about how we diagnose any other vasculitis in a patient with rheumatoid arthritis. All right, Emery, back to you. Just listen to Reza, ignore everything I said. But I challenge you to think about how you can diagnose another vasculitis in a patient with RA. I am stumped, but I'm curious to learn from Emery.
Okay, so an anchor panel was obtained, and it did show a very high MPO titer at 163, I believe. And an LP was obtained that showed a little bit of inflammation, but was nonspecific. There was no growth on the LP. And the final thought process was that this was CNS ANCA vasculitis, which it was a little bit kind of complicated why all those things were thought, because this is a very complicated case with lots of different things involved. Hematology was consulted about the results of the antiphospholipid, but just due to the only very low titer of the IgG to cardiolipin, this did not meet criteria. It was probably transiently positive in the setting of the recent COVID infection in the past. And so that was kind of like, we don't think this is antiphospholipid syndrome. And then the thought on the, my thought on kind of understanding of the thought process, I'd gone off of service kind of by the time everything came back, was that the actually joint disease from the rheumatoid arthritis was not there was no active synovitis, and it was like not thought to be active. So it was thought to be more likely to be the ANCA vasculitis, and I think certain characteristics of the CNS disease seem less characteristic of rheumatoid arthritis, but regardless, the answer was going to be immunosuppression. So to some degree, it was, I think, somewhat like, all roads lead to immunosuppression. But if someone knows more about, I was going to read kind of more about the rheumatoid arthritis CNS, but I just didn't have time. So if someone knows more, I would love to hear more kind of
Anne-Marie,
on the start process.
I am like giggling here because Robbie like ended his discussion saying like, hey, you know, we want to keep this broad. We've been on like a bad streak. And then he ended it with like ANCA, ignore the ANCA. And then you started by saying this is ANCA-associated vasculitis. I absolutely love it. Robbie, I tried to mute you as you were saying ANCA, but it didn't work. I knew it was ANCA. His lack of response is very awkward right
I'm
now.
so sorry. I'm so sorry. My
He's not laughing with me.
my mic is. I'm having the reason I have my video is my internet connection is very unstable, and I think it's perfect that I muted myself because of my internet in response to your muting. So carry on, my dear friends. Carry on.
All right, I think we're ready for Kiara to take us home. We're at the noon hour. Very excited, Kiara. Anne-Marie, thank you as always. You are brilliant and really appreciate your case presentation.
Thank you so much. It was an amazing case. I'm not so sure you're hearing me. Yeah, my internet connection is also unstable. We started with a neurochief complaint about facial droop. It was a left facial droop, so we were thinking about if this was isolated, like a Bell's palsy, or this was facial droop with something else that was very consistent with the case. So with facial droop and plus something else, like in this case, leg weakness, we have to think also about sinister causes like central nervous system or versus peripheral, like a cranial nerve disease. Also, we had a renal infarct. So when we have a renal infarct, we have to think about many causes, like a hypercoagulable state, maybe due to COVID infection, like this is a recent diagnosis, or any vascular risk factors. Also, we have to